قال ربك للملائكة إني جاعل في الأرض خليفة قالوا وتجعل فيها من يفسد فيها ويسفك الدماء ونحن نسبح بحمدك ونقدس لك قال إني أعلم ما لا تعلمون وعلم آدم الأسماء كلها ثم عرضهم على الملائكة فقال أنبئوني بأسماء هؤلاء إن كنتم صادقين قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم قال يا آدم أنبئهم بأسمائهم فلما أنبأهم بأسمائهم قال ألم أقل لكم إني أعلم غيب السماوات والأرض وأعلم ما تبدون وما كنتم تكتمون وإذ قلنا للملائكة اسجدوا لآدم فسجدوا إلا إبليس أبى واستكبر وكان من الكافرين وقلنا يا آدم اسكن أنت وزوجك الجنة فكلا منها رغدا حيث شئتما ولا تقربا هذه الشجرة فتكونا من الظالمين فأزلهما الشيطان عنها فأخرجهما مما كانا فيه وقلنا اهبطوا بعضكم لبعض عدو ولكم في الأرض مستقر ومتاع إلى حين فتلقى آدم من ربه كلمات فتاب عليه إنه هو التواب الرحيم صدق الله العظيم.
شكرا brother طلحة. جزاكم الله خير. Without wasting more time, we would like to introduce our first presenter. Our first presenter is Dr. Abdi Karim Salat Noor. Abdi Karim is a consultant physician practicing in Garissa County Referral Hospital. Abdi Noor has done his undergrad in Algeria some years back. I'm sure he doesn't want me to mention the years. He has practiced in Garissa for over 10 years, then he went for his M.Med. Please welcome Dr. Abdi Noor, or Abdi Karim.
Assalamu alaikum wa rahmatullahi wa barakatuh. The study I'm about to present was done by me. The first two doctors that are mentioned, whose names appear on the list are senior faculty members of Mbarara University of Science and Technology. The third doctor, Dr. Nightingale, is a senior cardiologist at Bristol University in the United Kingdom, who also played a role in this study. The first thing I want to mention, of course, Mbarara Regional Referral Hospital is in southwestern Uganda, and that's where the study was done. Now, I need to say two things about the title. Okay, just one, that it is iron deficiency. And please note, it's not iron deficiency anemia. Because now, it is now known that iron is a bigger disease spectrum, iron deficiency is a bigger disease spectrum than iron deficiency, than anemia. Iron is involved in more than 300 enzymatic reactions in our body, and therefore, long before you develop iron deficiency anemia, then you are iron deficient. Now, all right. So this is how we define heart failure. Of course, it was defined initially in the inclusion stage using the Framingham criteria, but of course we did echocardiogram and NT-proPNP for all the patients. Acute decompensation, I did not need to waste a lot of time on that. For iron deficiency, the parameters we used have the best sensitivity and specificity compared to the gold standard. Sorry. So heart failure is a very big comorbidity. I think it's known, or it affects over 60 million people worldwide. In sub-Saharan Africa, it is said to be responsible for more than about 7% of admissions in internal medicine wards. I think, I'm sure it's more, but there are no epidemiological studies. Now, mortality is also from heart failure is highest in sub-Saharan Africa. Sorry. So now, we know that heart failure is hard to treat because there is a lot of remodeling that are taking place by the time heart failure, by the time the patient presents with heart failure. And hence the need to focus on comorbidities that are associated with heart failure that can be corrected. Comorbidities that can be treated. And iron deficiency happens to be one of those comorbidities. It's known to have a very high prevalence, and it is associated with poor prognosis if it's present. So we are saying it is highly prevalent, and it has a prognosis implication. Now, what is notable is that more than 40% of those that are going to be iron deficient will not have anemia. And so, if you're going to be using a CPC and looking at the HP for you to do iron studies in a heart failure patient, you're likely to miss more than 40% of them. Now, here is even where it gets more remarkable. If it is treated, by day 7, the ejection fraction can improve. I don't know, the quality of the life of the patient can improve, and the risk of hospitalization is reduced. I don't know of which of the parameters, the drugs that are used in heart failure management where ejection fraction can improve within 7 days. There's a lot of talk about SGLT2 inhibitors, and everyone seems to be talking about it. I believe iron has not gotten a lot of attention, and hence the part of the reason why we actually did, so that we can generate a local data. And I also feel like, okay, I don't want to sound political, but I think Big Pharma has not pushed iron because there is no patent for it. Now, in Uganda, where this study was done, of course, it had one of the highest incidence of hospitalization. And iron deficiency, there was a study that was done in Tanzania by somebody called Professor Makubi. I think one of the person who has written extensively on iron deficiency in heart failure in Tanzania, and he found 5.9 odds of dying from iron deficiency. if a patient has heart failure. So it's a major cause of anemia. Iron deficiency is a major cause of anemia. Of course, we know in Africa, in our setting, patients present late. And late presentation and higher New York Heart Association class is associated with higher prevalence of iron deficiency. Now, let me jump that. So our main objective was we just wanted to increase the awareness of this among clinicians because it is actually hardly thought about. This is the conceptual framework that explains, which I drew, that explains the pathophysiological relationship between iron deficiency and heart failure, but I'm not going to take a lot of time on this because I've been given very little time. Now, the site, like I had explained earlier, was at Mbarara Regional Referral Hospital. The study population were adult patients who were admitted with acute decompensated heart failure. That is how we came up with our study sample size. We excluded patients who had EGFR of less than 30. So that is how we did our data and analysis plan, and here are the results. Now, for the baseline characteristics, majority were female. Majority of the patients were female. 54 years was the median age. You see, heart failure affects very young people in Africa, unlike in the Western world. HIV prevalence among the population was low, but many of them had hypertension as the underlying etiology. No wonder hypertensive heart disease is the #1 cause of heart failure in Africa now. It is followed very closely by dilated cardiomyopathy. So a few people had history of kidney disease. Most people are not on antiplatelets and anticoagulants. We checked this because, of course, the use of antiplatelets and anticoagulants causes the patients to bleed, and that can increase the risk of iron deficiency. Majority of these patients actually, consistent with the fact that they come late, had New York Heart Association class 3 and 4. Majority of them were not anemic. You can see the HP was about 12.0. So that was their median EGFR at 53. The kidney disease was not that much prevalent. And you see, overwhelming majority of them had their NT-proPNP more than 2,000. That is actually consistent with advanced heart failure. The median CRP was that, and there's a reason why we did that. In Mbarara, the most common underlying etiology that was found was DCM, dilated cardiomyopathy. And you see the majority of them had a very, ejection fraction less than 40. Now, to answer our objective one, which was the prevalence of iron deficiency among the patients who had presented with acute decompensated heart failure, we found that 84 out of the total, 150, that is 56% of them, were iron deficient. And you can see at 95% confidence interval, it's between 47 to 64. Now, when we try to substratify based on whether these patients were anemic or not, what you will notice is that you see these 43% of these patients were iron deficient, but the HP was normal. Now, when we look at the associated factors, anyone who had his CRP, high sensitive CRP, more than 3 had 7 times higher odds of developing iron deficiency. So at the same time, those who had significant fluid overload, like they had pleural effusions, they have ascites, that had 3 times higher odds of developing iron deficiency with a significant p-value and the adjusted, odd ratio. in our discussion, I'm not going to take much time. I mean, in other cross-sectional studies, for example, the study by Mukubi found 49%, but I need to point out that Professor Mukubi did not do any studies. He used indexes, hematological indexes of the CBC, like MDO, MCV, to do ions, to find the prevalence, and that might explain the lower prevalence that he has found. In India, they found 76%. Okay, Indians have the highest prevalence of iron deficiency in Asia. Okay, they take a lot of tea and they don't eat meat. Now, the other studies in Germany, they found about 54%. And among the associated factors, associated factors that were found elsewhere are not much different from the ones that we found in our setting. Now, here is my conclusion. That in that center where we did that study, more than 50% of patients who were admitted with acute decompensated heart failure were iron deficient, 56% to be precise, and a significant number of this population did not actually have anemia, but they were iron deficient. The factors that we found associated with iron deficiency was that I'd mentioned that earlier on. This we thought in my literature search of published studies, I did not find any study on iron deficiency in heart failure that was done in Africa. I feel ours was the first. Of course, it was a single center study, might not be generalizable, and we were not able to do ferritin. So I'll not be able to tell you whether this was absolute or a functional iron deficiency. We recommend if any patient is admitted with acute decompensated heart failure, please do iron studies. Don't look for anemia. If anyone who is, by the way, it is in all major guidelines, all major guidelines currently, because there are not enough data, especially in Africa. We're not thinking about it more often. From a scientific perspective, I think to do research is being a scholar, and that is just to encourage. I mean that we should be doing research. We shouldn't just be waiting for data from elsewhere. We should do research of our own. I need to acknowledge the following. Thank you very much for listening.
Thank you, Dr. Abdikarim Salat. I think that was a wonderful presentations. So we'd like to take one or two questions. The timekeeper is saying no, but just one question. Yes, please.
Assalamu alaikum. My name is Dr. Hatimi, pediatrician. That's a very interesting presentation. I think somebody should do one in Kenya. I have a question for you. I just wanted to find out, when you are recruiting these patients, were they on anti-failure regime when you are doing your iron studies? Because you said after a week, there was a lot of improvement in their ejection fraction. Were they on anti-failure, or is it that after recruiting them, giving them iron, you started them on anti-failure as well?
Thank you so much. I did an appoint prevalence study. The improvement I have pointed to is what has been proven in advance, that if iron deficiency needs to be looked for because it's a treatable comorbidity, and if you treat it, someone did a study and confirmed that if you actually, I didn't do that, so that was the background. You understand? That was the background. I was introducing my study. Why one needs to think about iron deficiency in a heart failure patient. Such that because it is a prevalent or a very common comorbidity, it is a treatable one. It is a treatable one. So for me, my study was a prevalence study showing basically the prevalence. So I just, and some were on an anti-failure regimen, others were not. So anyone who presented with acute decompensated heart failure was included in that study. And so it is all my investigations were at baseline at admission. All right?
I know there are a lot of questions that will trigger your answer. You trigger a lot of questions, but I think that is to whet our appetite, so that at least during the break time, we can grill him there, right? So without wasting much time, we'd like to present our next presenter, Dr. Salim Masoud. Dr. Salim Masoud is pulmonologist at KU Teaching and Referral Hospital, the private practice at Nairobi South Hospital, and a board member and treasurer at the Respiratory Society of Kenya. Welcome, Dr.
Thank you very much. Shukran. The pointer? Or who's moving the slides? So I apologize for my voice in advance. I'm just recovering from a flu. So how do you move this? Okay. Do you move from there? This is okay. All right. So asthma is a common problem. It affects around 3 million people worldwide. And not everybody who has asthma on treatment will end up having a good control. So there are a number of patients who end up having poor control. And this poor control is attributable to several factors. Some of them are highlighted there. So adherence, just like in any other chronic diseases, is a factor. And then another problem in asthma is inhaler technique. Not everybody, everybody knows how to swallow tablets or syrups, but not everybody who knows how to use the inhaler correctly. The other thing is suboptimal doses of treatment, and that applies to all chronic diseases. And then it's asthma because it also has environmental factors. Sometimes inability to control the environment may also make asthma control a bit difficult to treat. And then there are some other conditions which mimic asthma or even make asthma a bit more difficult to control. So if all these factors are there, and we usually classify patients what we call difficult to treat asthma. If you have any one of these, and patients continue having a problem controlling their asthma, we call it difficult to treat asthma. But when we try to control these factors and we make sure we have managed to control or take care of these factors, but again the patient continues having symptoms, then that qualifies as a severe asthma. And severe asthma is that one which you require high doses of inhaled corticosteroid to control, or even using oral corticosteroids to either have control, if you can, but you can also end up not having control despite high doses, inhaled corticosteroids and oral corticosteroids. So this is just a table showing the doses, which one classifies as high dose. So, I mean, the common molecules we're using a lot is budesonide, which is there. So doses of above 800 microgram is considered high. You can imagine the common inhalers you're using, they're around 200, and some of them are 400. So this is per day. So if you're going to use 400 twice daily, then you're already using, if you go above that, then you're high dose, you're using high dose corticosteroids. The other molecule used commonly is fluticasone, and we know there's a 250 and 500. So if you use 500 per day, this is already a high dose. So if you consider that majority of patients may end up having severe asthma and you're not aware, because we end up giving them budesonide above 800 and even fluticasone above 500. So this is the table, the stepwise approach in asthma management proposed by GINA. GINA is a global initiative for asthma treatment. So most of the patients you're talking about with severe asthma will be in step 5. So these are the patients who have high dose inhaled corticosteroids or oral corticosteroid to control their asthma, and probably some of them may not be able to be controlled even on step 5. If you look at this, majority of these patients, you'd advise as a medical officer or a general physician to refer these patients to a specialist. So we will be managing most of these patients, but this presentation is also to be able to for you to familiarize with this kind of patients. The reason why we are talking about biologics, biologic has been used in many other chronic diseases, especially those use continuous or chronic use of systemic steroids. And the reason is simply because even small doses of systemic steroids are associated with very high levels of mortality, morbidity, and hospitalization. So we're just talking about bouts of short course of steroids. If you take 2 or 3 times bouts of maybe 5 days or 10 days of corticosteroids, studies have shown that these patients have higher rates of comorbidities, hospitalization, and mortality compared to those who have not used steroids at all. So that's why we need and we want to reduce the use of steroids in patients who may end up need them. And this is not the first, because I mean, in autoimmune, in connective tissue diseases, people are moved away from using steroids, and even in nephrology, any chronic disease that immune mediated and requires steroids, people are trying to move away from their steroids because of the associated comorbidities and mortality. So severe asthma is common, is not rare. It depends on which data you're looking at. So the prevalence around 10% in adults and around 2.5% in children. And it is not a benign disease associated with morbidity and mortality, reduced quality of life, difficulty in breathing, what we call fixed airway limitation, and frequent exacerbations, going to hospital all the time because of exacerbations. And also it's expensive, you have to stay in a hospital, and there's a risk of death associated with it. So why do some people have severe asthma and some don't have? So these are the postulated mechanism, physiological mechanism for people who may be having severe asthma. So some people may actually have steroid resistance. The other thing is what you call remodeling. So you know, with asthma treatment depends on bronchodilation and inflammation. But if you have fibrosis that has taken place in the airway, so your bronchodilators and anti-inflammatory medication may not act when you have remodeling. The other thing is maybe some of the inflammation is so far to be reached by the inhalers, it is so distal, and it may not be reached by the molecule. And there are studies that have shown that smaller molecules in smaller particles like cyclesonide may be better compared to larger molecules like budesonide. So it is important sometimes to confirm if patients really have steroid resistance or they have issues with compliance. So patients may come with frequent symptoms, but if you interrogate, they may not be taking their steroids. So one way of looking at it or confirming is to give them a systemic intramuscular long-term steroid like triamcinolone, and then assess response. So if the response to the symptoms improve, then these patients do not have steroid resistance. You may just need to sit them down and talk to them about compliance. But if patients with triamcinolone end up continue having symptoms, most likely they are resistant to steroids and they are candidates for biologics. So severe asthma is not one disease, it's a heterogeneous disease. It comes in different aspects. So there are those that start in childhood, adulthood. There are those come allergic in nature. So severity of air limitation, some are very severe, some not. So it is not, but more importantly is the underlying airway inflammation in these patients. Because this comes importantly when we try to we try to pick the biologic, what you call phenotyping the asthma patients. So with phenotype patients, you have eosinophilic airway inflammation and neutrophilic airway inflammation predominantly. And we're going to look into that. So type 2 high inflammation is the most common. It consists around 70% of all asthmatic patients. It's mediated by these inflammatory cells, eosinophil mast cells, basophils, but importantly the interleukins which they produce, because this becomes target when we are looking at the molecules we used for treatment. So these are some of the molecules, these are some of the biologic agents used. There's anti-IgE, omalizumab, anti-IL-5, mepolizumab, reslizumab, benralizumab, and then we have anti-IL-4 receptor, dupilumab, and the anti-TSLP, tezepelumab. So when we are looking at these molecules or any other treatment intervention in asthma, this is what we are interested. This will be, we are interested mostly in these outcomes. These are the desirable outcomes in any intervention for any medicine, but more so in asthma. So we want to reduce exacerbations. We want to improve lung function. We want to decrease the use of steroids. We want to improve quality of life. We want to reduce inflammation, and also make sure the medicines or the molecules are safe, and also, if possible, have remission. Treat the disease completely. And also, importantly, is reduction of cost and utilization of hospital resources. So these molecules which have mentioned earlier, some of them were studied against this background. So one of them, omalizumab, was shown to improve exacerbations when compared to placebo. So this is a meta-analysis looking at several studies, and omalizumab showed significant reduction in the rate of exacerbations in patients with severe asthma. This is another study, meta-analysis, looking at symptoms, and omalizumab was shown to improve symptoms significantly in severe asthma patients. Another molecule, dupilumab, also reduced exacerbations. So another meta-analysis. So this is good quality data because it involves several studies, not single study. And all of them are RCTs, so quite significant data. Also, dupilumab also controlled asthma symptoms, and also the other parameter is lung physiology. It improves lung physiology when you do spirometry. So look there, there's increased lung capacity and volume. This is another target, the epithelial cytokine antibodies, the TSLP, which also have been targeted, and studies have shown using tezepelumab also reduced the rate of exacerbations. Again, this is a meta-analysis, quality data. And the other favorable outcome we want in these molecules is the reduction in the use of systemic steroids. So the other phenotype is type 2 low inflammation. This is not well studied. We don't have so many molecules for this particular phenotype. Fortunately, is the rare type. It consists around 20 to 30% of all severe asthmatic patients. So this is a study which was done in the US, looking at the patients who are put on biologics. Biologics are very expensive. They're not easily available. They cost around $1 million, I think 4 million in a year if you convert that into Kenyan money. That's treatment for just 1 year. So it's a very big issue, but we have to identify the people who really need them. But in the States, because of reimbursement from insurance companies, they put a lot of people on them. But looking at the people who are using biologics, many of them, half of them, did not qualify to be on the treatment. So this is a study looking that, firstly, we need to confirm. If you're to put these patients on biologics, first you need to really confirm, because they're useful but expensive. So majority of patients could have just done with reinforcement of the inhaler technique and reinforcement of compliance, and would have done okay, but they're put on these expensive medications. So when you start putting patients, then you review them just like you review with other asthma patients. You review them, you assess compliance, inhaler technique every now and then you adjust treatment, and then you review them again. So I will not go into this. In case patients do not respond to one molecule, then the options of choosing another molecule. And yes, this again, just to re-emphasize, asthma treatment is not just a set and forget. We have to continue. So it's a continuous cycle. You have this very nice wheel. Just tells us this is continuous. It never stops. We have to review patients, assess, and adjust all the time. So this is my last few slides. Just summarize how we are going to, if you were to initiate patients on biologics, first patients has to start from being difficult to treat asthma. So if patients respond to asthma, the inhaled corticosteroids, we don't have to do much. But if they don't, first, we have to confirm diagnosis, we have to optimize management, we have to correct correctable factors, and then from there, if the patients still have symptoms, then they would be candidates for biologics. Thank you very much.
Shukran, Jazakallah khair, Dr. Salim Masood. Dr. Salim Masood was my teacher and mentor in my undergraduate, and I still met him in my postgraduate, mashallah. Shukran for coming all the way from Nairobi. The message from his presentation is we are moving to precision medicine and therapy, and in asthma we try to avoid steroids, that is steroid-sparing medication, so that we can avoid complications. But all in all, we should choose the right patients to give the biologic, so we should choose them ethically. We'll take one burning 2 questions. You can see Dr. Hatim is looking at me. 1 question. Okay, so we all know targeted therapies and the biologics. I think we can move to, I knew you will have a question.
No, it's not a question, actually. Just clarification, yeah. Formoterol should be used in children above 6 years of age. Salmeterol above 4 years of age. So it's not a first-line reliever medication in pediatrics.
Can you repeat that again? There are a lot of
Salmeterol above 4 years of age. Formoterol above 6 years of age in pediatrics. First line, we use salbutamol as a reliever medication. Of course, you combine it with a steroid as a reliever. Thank you.
Thank you. We go to our next presentation, and then our next presentation is on cardiology. I think I'd like to introduce our pediatric cardiologist, Dr. Bakari, but the presentation will be made by one of the medical officers who has been working with Dr. Bakari for so long now. Karibu, Dr. Zainab Thabit.
Point. So my name is Dr. Zainab Thabit Mbarak. I am a medical officer at the Pediatric Cardiac Clinic at Coast General Teaching and Referral Hospital. The cardiac clinic is under Dr. Bakari Suleiman Mwashambi, who is the pediatric cardiologist at the hospital. So basically, Coast General handles patients around the coast, cardiac cases, and we also receive patients from Northeastern province as well. So first and foremost, I would like to thank the Kammp Association for giving us this opportunity to talk about pediatric cardiology for two main reasons. One is because I think pediatric cardiology is a neglected topic in this country. As we all know, there are very few pediatric cardiologists in this country. There are very few pediatric cardiac centers, and there's very little research done on pediatric cardiac diseases. And the second reason is because I have worked in the clinic for the last 3 years, and I'm here to share with you stories of these children because I think it's a high time we create awareness to the community so that they can be assisted. So the burden of pediatric cardiac disease is immense in Africa. Healthcare efforts have traditionally focused on combating communicable diseases, example, malaria, diarrhea, and pneumonia. Pediatric cardiac diseases emerges as an important health concern. Congenital heart disease is recognized as the most common congenital anomaly globally. It is becoming the second leading cause of infant mortality in high-income countries. Unfortunately, the exact prevalence of congenital heart disease is often unrecorded and underestimated in Africa. Financial challenges and lack of access to quality healthcare have been identified as the main reasons. Therefore, the burden of the disease is growing day by day, and this carries important implications on the future of the children and families in these regions. So the Pediatric Cardiac Clinic at Coast General was established in 2019. It is among the 4 government hospital pediatric cardiac clinics in the country. So it is a clinic that targets children with cardiac diseases and adults with congenital cardiac diseases. So far, a total of 1,100 children have been screened, and 600 out of these children were found to have complex cardiac diseases. So this represents 55% of the total patients screened. So the most common heart conditions seen at our clinic are as follows. Congenital heart disease is at 75%, rheumatic heart disease 10%, and dilated cardiomyopathy at 10%. And other cardiac conditions like cardiac masses, TB, pericarditis, which is also very common nowadays, at 5%. So congenital heart disease is around 75%. So out of all the heart conditions seen, congenital and rheumatic heart disease require cardiac intervention. So intervention can either be closed or open heart surgeries. So closed heart surgeries are the cath cases. So far, a total of 500 children require cardiac interventions. Among these, only 200 have had cardiac interventions. So this represents only around 60% of patients are still awaiting cardiac interventions. So far, Coast General have conducted 116 closed heart procedures and 84 open heart procedures from 2021. So our closed heart procedures is at 58% and open heart procedures at 48%. So clinic profile. So out of 600 cardiac patients, only 200 patients are active on clinical follow-up. A total of 163 patients have only visited the cardiac clinic once. So the whereabouts of these patients are unknown because of the following reasons. So lack of contact number. So most of the patients do not have phones because they are very poor. Number 2, accessibility to the clinic, because Coast General caters for almost 6 counties. So most of them don't come back to the clinic because it's very far. Number 3, lack of finances for medical interventions. We all know that cardiac pediatric cardiac surgeries are one of the most expensive surgeries in Kenya and even abroad. So one surgery is around 5,000 US dollars to around 20,000 US dollars. So if you tell a mother that the child has a cardiac disease, they never come back because it's expensive. Then breakdown of families. So most of the time, patients don't come back because if you tell a mother that the child has a cardiac disease, most definitely the parents separate. So you'll find a lot of single parents, or most of the patients are abandoned with their relatives because of this disease. Then change of contact numbers. Of course, this is something unavoidable. Then death. So most of the patients don't come back because they are just silently dying in their homes. So you can easily trace them because they're already dead. So to bridge the gap between the clinic and the patient, because General has conducted 15 outreach clinics for the last 2 years in these following areas. And mind you, all these are free free screening echo clinics. So the highest number was in Malindi and Garissa, but we conducted several camps here, more than one time. And the lowest was in Lamu. Lamu had the lowest turnout of patients, even despite us advertising. So total number of patients for intervention was highest in Nairobi, but because most of the patients that attended there were mostly cardiac patients, most of them had a cardiac disease already. But you can see the percentage is almost above 40. So it's still quite a high number. So a total of 948 patients were screened in level hospitals, and 455 of the patient had a cardiac disease, which represents 48%. Still high. Okay. So we went to Garissa twice, and we managed to screen patients in Dadaab refugee, patients who came from Dadaab refugee complex, and we managed to screen 36 patients. 20 of them had a cardiac disease that required intervention. So what I'm trying to say is that the disease is not just in places where there's access to quality healthcare, but this is also affecting children in refugee camps as well. This is one of the examples. So conclusion, there is a growing cardiac disease burden in Kenya, especially congenital heart disease. Most of these children are silently suffering and dying at their homes. Majority of these patients are unable to afford cardiac services. So recommendation, more pediatric cardiac screening centers should be established in the country. It's unfair to have 4 pediatric cardiac centers in the whole country to cater for all of these children. It's unfair. So increased training needs for pediatric cardiac specialists, especially pediatric cardiologists, especially congenital cardiothoracic surgeons. We lack that in our country. Pediatric cardiac anesthesiologists are also very few. Cardiac critical care nurses and pediatric echo technicians. And then reduction of costs for pediatric cardiac surgeries and easy accessibility of funding to assist this patient, because definitely 5,000 US dollars is not easy money to raise. Thank you.
Thank you very much, Dr. Zainab. I think they deserve a bigger round of applause, please. The work they are doing with Dr. Bakari from Coast General, actually, it's a great work, and I can attest to that because I work in Msambweni, and these guys are always ready when we send them patients for either cardiac echoes or interventions. I think it's something that is very, very commendable. She did well with her time. I think she's a good presenter. We give her another round of applause. Thank you. And of course, we give this credit to the mentor, and that is Dr. Bakari. Thank you very much. We'll take 2 questions.
Assalamu alaikum. Thank you very much, Dr. Zainab. I can. Yeah, okay. So thank you very much, Dr. Zainab, for a wonderful presentation. Doctari. So I come from Garissa, and you guys have, I can attest that the usually do there have really impacted a lot of patients. And for majority of the patients who couldn't access those services before, at least you were able to make a difference. So thank you very much. On the other side, why we usually get low turnout for those screening camps is probably the information gap for the parents or for the caretaker of the child. So because if the parent doesn't know what to look out for in the kid who has a congenital heart disease or who has a heart disease, then it becomes a bit difficult for them to pick up those signs and symptoms, and then for the screening and talks. And the specialists go down there. We have.
Thank you. I think that's a challenge to come. I think that was a comment, not a question. Yeah. I think because of time, we can let Dr. Zainab sit. We'll be interacting with her, inshallah. Yes? Okay. Okay. So thank you very much. So now we are going to the next presentation, and the next presenter is none other than Dr. Zahra Muhdar Omar. I'm proud to present Dr. Zahra Muhdar Omar because we did internship together. I can see she's just written here. She has more than 10 years of experience, and I guess I also have more than 10 years of experience. So Dr. Muhdar, Zahra Muhdar is a specialist obstetrician and gynecologist. She did her undergraduate from Poland in, how do you pronounce this? Huh? Wrocław. So from Wrocław Medical University in Poland, she did her postgraduate from Muhimbili and also did training in research and IVF from a center called Ashish in India. Let's give her a round of applause as she gives her presentation.
Assalamu alaikum. I know many of you have been waiting for this presentation, so I will get to it. Today I'm talking about in vitro fertilization, and this affects most of our infertile couples that we see. I'm going to give you a definition, talk to you about the different protocols, the indications, and the Islamic perspective on it. IVF is a form of artificial reproductive technology that involves fertilizing an egg with sperm in a laboratory dish. An IVF cycle involves several steps that might take 2 or more weeks to complete. And we use the normal menstrual cycle. That's when we begin the treatment. Transfer of a good grade embryo is done once the uterus has been prepared adequately for implantation. These days, we do not do a lot of fresh transfers. Most of the times we do frozen transfer. That is after we have picked up the eggs, we freeze them, we let you heal for a while, you wait for another menstrual cycle, and then we can transfer back the embryo to you. It is believed that over 10 million children have been born due to ART globally, and approximately 2.5 million ART cycles are performed annually. This is worldwide. And this results to approximately 500,000 babies born each year. So if I give the Kenyan example, minimum we have 10 IVF cycles. In Mombasa we have 1, so maybe around 12, maybe 13. Per month we do 25 cycles, so that's 250 IVF done every month. So if you do the math, at the end of the year, and not all of them have to result in babies, so it's a good figure for Kenya. So this was the first success in 1978. This is Louisa, and right now she is 45 years old, and she has a child of her own through natural conception. So the babies born through IVF are totally normal, and they can conceive later and fully function as normal kids. The indications, I have divided them into male, female, genetic disorders, and for fertility preservation. So for female factors, we have fallopian tube damage or blockage. That is a clear indication. Ovulation disorders like polycystic ovarian syndrome, endometriosis, advanced maternal age, unexplained infertility where you have researched and done everything to the couple, but you don't find a cause, so we label it as unexplained, and it is about 40%. And then we have recurrent miscarriages. So through doing IVF, we can alter some of the reasons why you are getting miscarriages, and we have a control over it. And then the male factors, we have low sperm count, low sperm motility, moderate, severe grade male infertility. So if we are going to use 1 egg, and we are going to use 1 sperm to do IVF, and mashallah, the males produce more than 200 million sperms, we do not need a lot. Men with low sperm count and low sperm motility, we just need to find 1 that is functional. Genetic disorders like pre-implantation genetic testing for aneuploidy. In case in the family we have a high risk of maybe Down syndrome, Patau syndrome, we are able to do, after we have the embryo, we can do a biopsy and send this for pre-implantation genetic testing, and they will give us back the results that, yes, this one has 46XX, 46XY, so it's not a Down syndrome, and then with this embryo, we can transfer it back to the mother, reassuring her that, inshallah, it will not be a sick baby. We can also do for monogenic disorders. Yesterday we talked about cancer, that we have increased breast cancer. So assuming the first degree, you have a mother or you have a sister who has a BRCA antigen. So you need to do the test. The embryo will also be done a genetic testing for monogenic disorders. So we will know whether that embryo is carrying the BRCA gene or not. And if it's not, then we transfer that embryo. So we are able to slash the diseases out and give you a purely healthy embryo. For fertility preservation, we prefer to freeze embryos, but also for the unmarried and the undecided, we also freeze the eggs. For patients maybe who have cancer and require surgery or chemotherapy or radiotherapy, so we cryopreserve for them. Even the sperms can be cryopreserved. And sometimes we do it electively because women, we know purely that after 35, the egg quality decreases, so we can cryopreserve for them electively as they pursue their career or as they have not found the right spouse for themselves. So the basic testing, what happens is we do an ovarian reserve testing, that is the anti-Mullerian hormone, which is very important. It tells us how much eggs are left in your ovaries. We have the other hormones like the FSH, TSH, and prolactin. They all have to be in a baseline. And if there is any variation, we have to treat it first before we start the IVF procedure. Understanding the quantity and quality of the follicles, this is easily seen through an antral follicle count through a transvaginal scan. So most patients come to us, we will just do the pelvic exam or the pelvic scan. That is not satisfactory. You have to put a transvaginal scan that gives you a picture in zoom. You have to count the follicles that they have from day 2. That is the most appropriate day. And when we are young, we have more than 10 follicles. So that's normal. It doesn't mean you have polycystic. And when you get older, we see that they are smaller and the quality is not good. So that alone can be told through a transvaginal scan. Always prefer a transvaginal scan. We have a uterine evaluation. From the vaginal scan as well, we can evaluate the uterus and see if there's a polyp, if there's a fibroid, and then we seek treatment for these first, or we can do the ovum pickup first, because every month the egg number decreases. So we can do the pickup, and before your transfer, if there was any polyp, we can do the polypectomy later before the transfer. And then we have the basic thing for men, semen analysis. Sometimes we also add hormonal depending on the history. Infectious disease screening, which is mandatory, HIV, syphilis. Genetic screening, PGTA. Trial embryo transfer, these are done during the process. And then we have blood tests for other health checks. So we do consider diabetes, hypertension, and all those things. So the declining sperm function, WHO have been very lenient with men. We all know the famous graph above 35 years. We have a trend that is declining for female. But now we also have a trend which is declining for male. And WHO have reduced the numbers from before. So this looks like this. Before 1973, we used to say, oh, men had very good sperm quality, they have a very good sperm motility, but these days, you can see it's at 49 from 101. So yes, men also have a graph that is declining. Above 40, we can't say, oh, I'm still young. Above 60, I'm waiting, yeah? So this is a step-by-step cycle of the IVF process. First, we start with the diagnosis, as I explained, and then we start the ovarian stimulation on your day 2 or day 3. This consists mainly of injections. And then we go do the egg retrieval after triggering you with an HCG injection. And then the same time, we have a sperm retrieval, and the egg is fertilized, usually through ICSI. And then later on, as I explained, we do frozen transfers. The embryo is transferred back to the mother. So this is an example of the most common protocol we use these days. It's called the antagonist protocol. So on your day 2 or 3, you will come. We do the transvaginal scan. We see maybe we have 3, 4, 5 follicles that we are using this month. So we try to make them bigger. We try to make them more. We know every month a woman has 1. So if you're going to spend money on IVF, we try and make you have more, because they are there, they just need the stimulation. So we give you some injections, and every 3 days we do a scan, and then on a certain day, once we see they are above 16 millimeter, we give you an antagonist injection, and then we trigger you for the ovarian pickup. So once the pickup is done, it's fertilized with the sperm through ICSI, and then we wait a bit for 2 cycles and then transfer back. So this is a typical antagonist protocol. And the good thing these days, we have AI. If someone is thinking of doing fertility, please invest in a very, very good scan, because this will make your work, even if you don't know how to use scan, because we are not taught in even postgraduate. But if you have a very good scan and you have someone who will show you hands-on, so this one is I think is a GE, and they use AI. So these are all follicles, right? And the system there is called Sono, will mark for you the follicles. So if I'm doing for you a scan every 3 days, it's the same color of the follicle which will be there, and they tell you how many centimeters they're growing. So for this one, I think it's about day 14 because the follicles look good. And we trigger you once they're about 18 to 20 millimeter. That means to me, you're nearly ovulating. So all these will be harvested thanks to AI. So the ovum pickup is not a very serious thing that people think you'll go to theater, something is done. We just do a normal transvaginal scan is attached to a needle and then sucked, right? So all these eggs that we have seen here will be sucked and they are taken into a test tube. And then after that, they are fertilized through ICSI. Oh, so these are the eggs, the small ones here. So the extra tissue and the blood which was there will be removed, and this is a good M2 oocyte which is now going to be fertilized through ICSI. This is intracytoplasmic sperm injection. Yes, we do have the normal that you just leave them, but if you're going to do IVF, it's better to increase your chances by using ICSI. And then we incubate them and see. So it's not like we are interfering in all the processes, and this is a very good day 5 blast. This is what we normally transfer back. And so as I said, we wait until you're fully healed, or maybe you have to take care of a fibroid, you have to take care of a polyp which is inside. So all this will be frozen until you are prepared well to receive this embryo is when we transfer back. Transfer back doesn't even need anesthesia. It's like putting a coil. You just need a small catheter and the embryo is inserted back. And we tell you, okay, now let's pray and wait and see if the embryo will stick. After 2 weeks, we do your beta HCG. If it's positive, it's positive. So the Islamic perspective on IVF, seeking treatment for infertility is permissible and encouraged in Islam. ART is allowed provided that the source of the sperm, the ovum, and the uterus come from a legally married couple during the span of their marriage contract. No third party should intrude upon the marital functions of sex and procreation. Womb renting, surrogacy, is not accepted in Islam. An excess number of fertilized embryos can be cryopreserved and transferred to the same wife when they are ready for another child. And the frozen sperm or embryos are not permitted to be used after the death of husband or when they are divorced. As the Westerns, they normally do, oh, this is the last piece of my soulmate, so I would like to have it. No, in Islam we have strict rules of inheritance and strict rules of nasab, so you can't use something that you have frozen before when the spouse is not there anymore in your life. From the Quran, we have the story of Prophet Ibrahim, we have the story of Prophet Zakaria, and the Prophet himself, he said that marry the kind and fertile women who will give birth to many children, and I shall take pride in the great numbers of my ummah. So we can see that Islam gives strong and unequivocal emphasis in high fertility. Artificial reproduction is not mentioned on its own as in the primary source of Sharia, right? In the Quran and in the Hadith. However, when procreation fails, Islam encourages treatment. Because there is treatment, Allah has given us the technology to do it, we are allowed to pursue this treatment. Attempts to cure infertility are not only permissible, but they're also encouraged. And the duty of us as doctors is to help the couple achieve this pregnancy, conceive and deliver the baby in a halal way. ART was accepted after prestigious scientific and religious bodies and organizations issued guidelines, and these are the different people who came up with the fatwas. We can see there's one from Cairo, there's one from Mecca, and these are very long time ago. We can see from 1980s. So it's something that has been done for a while. In Kenya, the oldest IVF center was there from 1992. So IVF has been done in Kenya. And as female Muslims, We have been upcoming now. I know there's one here in Mombasa, and we are there in Nairobi. So please don't shy away and don't stay with your patients for long. You are checking this, you are checking that. Once you've seen there's an issue, please refer the patient to the appropriate fertility center. Thank you.
Thank you very much. That was an amazing presentation and very intriguing. Dr. Zahra is available at Victoria IVF Center in Nairobi. We'll take 2 burning questions. 2 burning questions, one from Prof. Zahida Qureshi.
I think this was really interesting, and I'm happy to see that our young gynecologists, the Muslim women, are coming up in this initiative. I just wanted to inquire if you have a permanent embryologist working with you, or do you then batch up your patients and then invite somebody from overseas and then do them in batches? Thank you.
We do have an embryologist in Nairobi right now. I think every center has a permanent embryologist. We rarely batch. I know in Mombasa they batch, but for us we rarely batch. Patient comes once everything has been done, the baseline investigations, we start the cycle. And a good point Prof has raised, as you can see, we are Muslim women here. I encourage, you don't have to be a doctor to do embryology. You can be a microbiologist, the lab tech. You can start with andrology and then pursue your career in embryology. We really need Muslims, first of all, and then we need Muslim female embryologists, because the patient trusts me as a Muslim, and the same way the patient will trust you as an embryologist with their embryos. There are so many, I don't know if I can mention, so many unethical and un-Islamic things that can happen with fertility. So it's really important. I'm encouraging all the young women here, please, if you think you're interested in these things, andrology is good, embryology is good.
Assalamu alaikum.
Wa alaikum
It's an important topic. I wanted to ask, what are the challenges you face patients who come and they have believed that it's qadar of Allah not to have a baby? Do you face the challenges, and how do you go around it? Because sometimes when you mention it to some patients we see, from my perspective, a cardiology, they'll tell you, kama Mungu anijalia hivi basi, I should not fight qadar. I don't know from your angle, how do you go about it? And do you face these things?
Yes, true. We do face a lot of challenges, and one of them is usually when the couple comes to me, they're already in a stressed situation, family issue, maybe pending divorce, or the in-laws are prodding a lot into their life. Why you've stayed 5 years, no kids. So they're already in a very stressed situation. And yes, some will tell me, oh, like, yeah, mimi nishakubali kadri yangu ndio hii. I'm like, okay, so Allah brought you to me. Maybe I'm sure you have prayed all this tahajjud and everything. So Allah brought you to us here, and we are going to try to help you. So when this process is over and it didn't work out for you, it's not 100%. IVF is never 100%. So if it didn't work out for you, you will know, yes, I have done everything according to what science has there and what Allah led me to do, and then, okay, I accept. Now everything is done. But so we have a lot of, we have a counseling, a psychologist who will counsel them first, because they come with a lot of burden. And then also we have someone who will teach them all the steps. This is what is going to happen. It's nothing extraordinary, as you can see. It's just taking some injections, doing the procedure roughly 2 weeks. So we try to explain to them step by step, and in the end, most of them do agree. And it's not everyone that we do IVF first. According to your baseline investigations, we can either start with an intrauterine insemination, or then we go to IVF.
It's a quick question. If you can answer that, I'm sure it's going to guide a lot of people.
Yes.
In terms of the costing, I know the costs vary quite significantly all over the place. Maybe you can tell us what's the average cost in the market, and what is your average cost? I know it can vary from patient to patient, but end to end, if somebody was to refer a patient, because most of the people here are primary care health practitioners, if they were to be told, be told how much is it costing, well, a general answer in terms of the general market, the range, and on average at your facility.
Okay, so we are trying, having these IVF centers in Kenya, we are avoiding going outside, right? India, Turkey, Egypt. The cost, if you are to do IUI, is around 70,000, and if you are to do IVF, comes to about 700. But that depends on the issues that brought you there, yeah? So you might have to do other surgeries that are not in the package of IVF. And I always advise, like for me, I see most of the patients in Isli first, because it's cheaper there. All this hormonal profile, if you were to go to a big lab, they will tell you it's around 40, 50,000, no offense to the lab people. But yes, we do, we do have very good labs that are cheaper. They give you the same results, yes, depending on the place. So after we have done all the workout, the HSG and everything, that's when I take you to Parklands, simply for just the procedure. So it's around 700,000.
Okay, can I ask, your data on male sperm count with aging?
Yes.
I don't know if this is for you or urologist. I mean, do we have a chance of stimulation just like women?
Yes.
And the other question would be the harvesting of the sperm. I mean, is very cumbersome for men, you know, doing it on a cup. So is there like injections we can we can have?
Okay.
Tough
so,
questions.
Yes, first question, we do have stimulation for men. If we see there was a hormone issue, it's not obstructed, it's just there, it's not being stimulated, so we stimulate. I work a lot with Dr. Aidid, who was here yesterday, the urologist. We give them injections for, let's say, a month or 2 months, but to see good results, you need 3 months. And because sperms are not like eggs that come every month, sperms are produced every 21 days. And then for the second question, yes, putting your sperms in a cup might be a problem, but for like our center, I can say we have the sperm analysis room that is very comfortable. You can go there with your wife. And then if there is an issue, usually if you don't have an issue, you're able to produce. But if there's an issue, we do help with various other medications. And if there's still an issue, there is electrostimulation that can be done to give you the sample. And even if when there's an obstruction, we do something called epididymal sperm aspiration. So it can be just aspirated from the epididymis. And lastly, if we don't get anything, we can do testicular sperm extraction. So we go to the testicle and manually remove a whole tubule. Yes, because we only need one.
This is very interesting, and I know there will be so many questions.
Yes, so men are thinking of themselves, right? But they don't see this whole process, what women go through. They just have to give us in a cup. That's it.
Okay. We'll take the last question from Dr. Prof. Dabar.
Thank you very much, Dr. for that wonderful presentation. And I think, as someone really said, more often than not, most of the problems actually is, particularly our Somali community, we place the burden on the lady without really talking about. And the ladies harassed, and as you mentioned, mostly from the in-laws who really are so quick to have maybe a grandchild or whatever. And I think this issue of really going to, don't stay in Isli, it's good sometimes to come to Garissa and other places and give this, particularly in the refugee camps and other big centers, so that you can have audience with the mothers, because there are a lot of really couples who have got this problem. Number two, the issue of marry women with who can give more children is good, but it also applies. How do you use that one for family planning? I think that's the issue is the Prophet saying don't control about the birth, you know. Yes, we like to have, but also, of course, we take care of the lady, but in a way that is not actually, not I'm going to give all the 2 children. I cannot able to do more than 2 because of my work. I don't, Islam, that's not allowed. But the last one, which I wanted, is how do you control, because of the ethical problems of human beings, and particularly in our community, this freezing, no fiddling with or interfering with by sperms and exchange or whatever?
No, so the process is, there are cryo tanks. These are big, big tanks with nitrogen gas, liquid nitrogen. And each stick is labeled for 1 patient with their initials and the age. Like one cryo tank will be only for sperms, and once it's frozen, it's in glass state, so it cannot transfer itself to another stick. So there's a different one for embryos, there's a different one for eggs, there's a different one for sperms. And most of the ones I have seen which are being cryopreserved are for patients who are young, maybe with cancer issues. Or sometimes, because these days we live in different continents, some husbands work very far away, so we are able to freeze their sperms and use them once the woman is ovulating. So it's totally possible, because the husband will stay with you 1 month in a year and expect you to have a child for him, right? So we do have such an option.
Thank you so much.
Shukran, Jazakallah khair. I think this is an interesting topic, and Tasha brought in an important point that most of the Muslims are actually believe in Qadr, okay? And it's important for us to give them the options because of technology. Allah says in the Quran, who is a Hafiz here? وَيَجْعَلُ مَنْ يَشَاءُ أَقِيمًا. Okay, so most of the Muslims believe in that ayah, and they believe is Qadr. But again, it's also Qadr that we have these scientists who are able to give us options. This is an interesting topic, and Dr. Zahra is available for all of you to ask questions. Some of us already have some family members who are struggling, some of our patients who need these options, and it's always good to give that option out. Shukran, Dr. Zahra, for that.
The issue of Qadr, I stand corrected. It doesn't prevent us to do. You believe in. I think there was a hadith of the Prophet ﷺ where Ashabi really say that, shall I tie my camel or I put my trust in Allah subhanahu wa ta'ala? I stand corrected, yeah? And he said, tie your camel, and at the same time, trust God. So if Allah subhanahu wa ta'ala has given us alternatives, why not? Yeah? And this is really the ni'mah which was not there before.
Yeah, Alhamdulillah, this is the ni'mah of Allah. Yes, and we've been told to seek remedy, and we've been told to read. That's why the likes of Dr. Zahra went and studied on IVF, and they are here to give us the knowledge and the options. So I think it's right for us to seek those options for our relatives and our patients. Now, the next presenter is Dr. Abdul Fattah Hassan. Again, I'm happy to present people that I know and people who are my friends. Dr. Abdul Fattah Hassan is an ENT surgeon currently based at Port Reitz, Mombasa County. He did his undergraduate degree from the Saratov University, postgraduate degree from Uganda, Mbarara, and he's currently working at Port Reitz and also doing private practice. He's going to take us through obstructive sleep apnea. For us physicians, we know obstructive sleep apnea is a cardiovascular disease. He is going to tell us in the ENT perspective.
Thank you, Dr. Maalim. Assalamu alaikum wa rahmatullah. I want us First, I wanted to share this slide. Actually, I just added it in the morning. I thought we should just have an idea on why sleep is important in the Islamic perspective. And there is an ayah in the Quran, Surah Al-Rum, verse number 23. And of his signs is your sleep by night and day, and you are seeking of his bounty. Indeed, in that are signs of people who listen. Okay? So this speaks about basically the importance of sleep in Islam. And the Prophet ﷺ also mentioned in the hadith what are the sleep hygiene measures that you can apply in Islam. In relation to our topic today, positioning yourself when sleeping is very crucial. So before that, first you need to perform wudu before you lie on bed. Then after that, you need to dust off your bed, then lie on your right lateral position. In relation to our topic today, because you're talking about obstructive sleep apnea, obstruction happens especially at night, especially when you're lying in a supine position, okay? And it has been shown in studies that those patients who lie on right lateral position, they tend to breathe better when they're sleeping, yeah? And this was in comparison with other positions like supine position, left lateral position, and prone position. We're going to discuss that in the coming slides. So let's go back to our discussion points. So first we'll talk about what is obstructive sleep apnea. Then we'll mention what are the risk factors and how common this condition is in our community. Then we'll also compare between pediatric and adult OSA, because there are similarities, but also there are important differences. Then what are the management options available, both medically and surgically, okay? So obstructive sleep apnea basically means when you have obstruction of breathing when you're sleeping. And this happens mostly at night, but it can also happen during daytime. And it can affect both children and adults. So what happens is that when you're sleeping at night, basically even the muscles sleep. Physiologically, you are in relaxing position. So you tend to develop obstruction of airflow down into your lungs. So this can cause reduction of airflow that is known as hypopnea. So hypopnea is when you have more than 50% reduction of airflow within 10 seconds. And apnea is when now there is cessation totally. There's no airflow that is going through from the upper airway, from the nose all the way to your lungs, okay? And over time, this can cause some complications such as cardiopulmonary, metabolic, and also neurocognitive complication that we're going to discuss later on. So how do you diagnose this condition? Majorly, history is very crucial, especially in pediatrics. So when these patients walk in, when these kids walk in with their parents, you need to first take a good sleep and medical history. And you also need to examine physical, and you're going to realize that when you do your normal ENT exam, in relation to the ENT surgeons in the room, you'll be able to see those findings that are very typical in those children with obstructive sleep apnea. Then to confirm your diagnosis, you need to do PSG, polysomnography, which is, at the moment, is not easily available. It has recently been opened in Nairobi, in Aga Khan University Hospital. They're actually doing sleep studies. It's quite expensive. So because of that, there are limitations to when it comes to confirming your diagnosis. Yeah. Okay. So we're going to differentiate between the two. The pediatric group, it's very common. Especially the most common finding that we'll see in these kids is up to 25% of cases is habitual snoring. And this is when the parents tells you that my child tends to snore at least 3 to 4 times at night for the whole week. And globally, up to 4% of children suffer from obstructive sleep apnea. And what are the risk factors? And the commonest cause of pediatric obstructive sleep apnea is adenotonsillar hypertrophy. And you'll tend to see this finding in preschool children because these are kids between the age of 1 year up to 4 years. And this is a time when the lymphoid tissues, the adenoids and the tonsils tend to grow at a very high rate. So in relation to their airway space. So they tend to present with very large tonsils, and when you do your radiological examination like PNS X-ray, you'll tend to see they also have adenoid hypertrophy as well. So also children with craniofacial anomalies. So children with Treacher-Collins syndrome, Crouzons, they also have additional airway abnormalities such as tracheal stenosis, also some maxillofacial anomalies that tend to worsen the airway space when they're lying down at night. So obesity has been shown also to be a risk factor, especially in older children. So what happens in obesity is that there's deposition of fat in the upper airway muscles. So this also causes obstruction at night. And finally, neuromuscular disorders. Yeah? In comparison, in adults, it's actually very common. And it is thought, globally at the moment, it's thought to be affecting close to 1 billion people globally. And males are affected more than females. The reasons are not very clear, but one of the theories is that men tend to have a larger neck circumference, more than 17 inches, and this can actually impair their breathing when they're sleeping at night. And also, it is thought that men tend to deposit a lot of fat behind their tongue. So we're going to see in the pathophysiology how this happens. And another risk factor, of course, we've mentioned obesity and the reasons why. And family history, neuropathy, and menopause also play a role. So I want us to look at this image here. Okay. So the pointer is there. So when you look at the normal airway anatomy, are you able to see? Is it visible? Okay. So the upper airway basically starts from the nose all the way down to at the level of the subglottis. That's just under the vocal cords, yeah? Then down there from the downwards, that's your lower airway. So in OSA, what happens is that the biggest culprit is the tongue. And there's an important muscle in the tongue known as the genioglossus muscle. So this muscle is the one that depresses the hyoid bone when you're sleeping. And physiologically, we had mentioned that when you're sleeping at night, your muscles also tend to sleep. So you can imagine when you're lying down, let me just go to the next slide so that I can be able to be more clearer. So you can see this is a baby. So when you can see what happens to the tongue, yeah? It falls back and blocks the entry of airflow down to your lower airways, yeah? So that is one. Other muscles that are involved now the muscles that form the soft palate, okay? Because these ones also, when they collapse, right, they block flow of air from the nasopharyngeal space down to your oropharynx that's supposed to be going down to your larynx, okay? So this image shows now the narrowing that happens at the level of the oropharynx, okay, as it flows down, because you see these, in obese individuals, you have this fat deposition at the level of the tongue, and this also causes constriction of airflow at the level of the hypopharynx, okay? Another contributing factor is when you have fat deposition, this will also cause collapse of your lateral pharyngeal walls, and this also contributes to the upper airway obstruction. And we also have some maxillofacial anomalies that can happen that can also cause obstruction of airflow. One of them is when a patient presents with retinognathia, where you have your mandible pushed backwards, and that also contributes to airflow problems. So I'm going to skip this slide. I'll only mention this figure here. So this is basic pathophysiology, whereby you have, there are two pressures. We have intraluminal and extraluminal pressure. So when the extraluminal pressure increases to the point that it's unsustainable, it causes collapse of the intraluminal segment, which is now what we had mentioned earlier of fat deposition, how it affects the integrity of the upper airway, okay? So Dr. Malim, when he was introducing me, had mentioned how OSA can contribute to cardiovascular diseases. Actually, it's very true, and this condition is so undiagnosed because most of these patients, they just report snoring, but they do have, it does affect their quality of life, especially in adults. Adults usually present with daytime symptoms, things like headache, daytime somnolence, easy fatigability, and the rest, yeah? So So what happens is that during obstructive sleep apnea, all these events take place, yeah? So patient gets aroused, okay, because of this apnea, hypopneic spells at night when they're sleeping, and this increases the catecholamine levels in the blood, which eventually causes hypertension and tachycardia, okay? Over time, so these are your outcomes. So you have hypertension, cardiovascular diseases, heart failure, arrhythmia, and stroke. Yeah? So what are the common clinical symptoms in pediatric OSA? So in comparison with the adults OSA, pediatric OSA, commonly, the children usually have nighttime symptoms. So you have restless child at night, keeps waking up every time, snoring, hypopnea, apnea spells, enuresis, and sweating, yeah? During the day, the parent will tell you that my child is always, he looks always tired, mouth breathing. It can also affect their development, and also they have concentration or behavioral issues, especially at school. The teacher might report that the performance is declining of this child, and one of the indicators is OSA. So on examination, usually when, these are what you see commonly, when these kids walk into the clinic, they tend to be breathing with their mouth open. So this image basically shows adenoid fasces. I'm sure the pediatricians are very familiar with that. So you also need to check for other physical findings, such as if a child looks syndromic, especially Down syndrome is quite common, and you need to be aware of that. On examination, so when you just do your oropharyngeal exam, you'll realize that the tonsils are enlarged. Adenoids, you'll not be able to see them just by naked eye. You might need to do an X-ray. It's not routinely done unless if it's really needed. For example, if you're planning to do surgery, or maybe you've treated and there's no response to treatment. Flexible nasopharyngoscopy can be performed. And this is done if you're suspecting there are other additional upper airway anomalies that you need to rule out apart from the adenoids and the tonsils. Okay. So we had mentioned the gold standard is polysomnography, and this is basically an overnight study, sleep study, that patients, they need to get admitted, and there are electrodes that are placed in their heart, in their nose, in their head. So they check for all this, yeah? So they measure your oxygen saturation, check your air flow from the nose all the way to the larynx, so your chest movements, abdominal movements, and also your brain activity, okay? So using the PSG, you'll be able to grade your OSA severity from mild to severe, okay? So you need to use an index known as the apnea hypopnea index that will tell you how severe this OSA is. So anything that is below 5, AHI of below 5, that is mild. Anything above between 5 and 9, that is moderate OSA. And anything above 9 is severe OSA, okay? So when do you do it? It's not routinely done, as mentioned, because one, it's not easily available and it's very expensive, but you might need to do in such situations if you're dealing with a syndromic child, you have a patient with craniofacial abnormalities, neuromuscular disorders, sickle cell disease, and obesity. The guidelines that have been talked about by the American Academy of Otolaryngology, head and neck surgery, they mentioned that PSG is also indicated in the case of if you're planning to do surgery in a child with all these abnormalities like Down syndrome, craniofacial abnormalities, because this is going to inform the anesthesiologist on if this child will need to get admitted to be monitored after surgery or not, okay? I've put this image here because this is actually, this patient came to see me last week. This is an adult patient presented with long-standing history of snoring and mouth breathing at night, yeah? She's around 55 years old, and when we examined her throat, this is what we saw. So you can see this is an oropharyngeal exam that is showing enlarged lingual tonsils. So these are tonsils that are located just behind the tongue, okay? And it's actually causing total obstruction of airflow. And this is a clinical scenario whereby now you'll need to discuss with the patient on the treatment options, and these are patients that actually benefit from lingual tonsillectomies, okay? Okay. So I think we've covered how to diagnose OSA, both by history taking and clinical examination of your patients. The next thing I'll mention is, thank you, other methods of other diagnostic techniques. You can do a home sleep apnea testing. Overnight pulse oximetry is easily available because you can just put a pulse oximeter and monitor for the heart rate and the saturation levels. However, this cannot help you distinguish if you're dealing with a central apnea. because central apnea actually is when you have cessation of breathing without efforts, breathing efforts. So that is hard to distinguish, okay? So we had mentioned this. I'm going to skip it. I'll only mention that, you know, the reasons why it's thought this to happen is that nocturnal growth hormone secretion appears to be decreased in these children, and also because they use a lot of effort in breathing during sleep, so hence failure to thrive. Yeah, we also mentioned this. So how do you manage? We can start managing these patients by as simple techniques as behavioral measures like lifestyle changes, things like weight loss, regular aerobic exercises, abstinence from sedatives, because they have been shown to worsen the relaxation of upper airway muscles during sleep. So if the patient is using any sedative, you need to advise them to withhold. So postural changes, we had mentioned this earlier when you are starting. So they medically, OSA can be managed by CPAP, yeah? We are all familiar with this, and it's the primary therapy for individuals with symptomatic OSA of any severity, okay? And how does it provide, or how does it prevent upper airway collapse? That is by acting as a pneumatic splint. And it has been shown that those patients who have been put on CPAP therapy, over time, when you follow them up, it actually normalizes their apnea-hypopnea index in more than 90% of cases. And this is when the patient is compliant. It's not very, sometimes you can have issues with compliance because they need to be wearing these masks for at least 4 hours, 4 to 6 hours a night. And there, of course, there are side effects, things like skin abrasions around the face because of the noise from the machine, and also rhinitis, yeah? So surgically, how do you treat them? It depends on now the cause, especially in children. Children usually benefit from adenotonsillectomies, but we have risk groups, children below the age of 3 years. These are children who might develop anesthesia-related complications, so you need to observe them while after surgery, at least for a day. Children who have severe OSA on PSG, and these are special growth because these are mostly anesthesia-related issues, especially after surgery when they're recovering from the surgery. It has been shown that they forget to breathe because you have relieved the obstruction and they get a hypoxic drive to the brain and they fail to breathe, and you can easily get into problems. We have had cases where you finished your surgery and the child is in the PACU, and you realize that your saturation starts dropping drastically, and this is because of one of the implications of surgery. Okay. Other surgical treatment options are uvulopalato-pharyngoplasties. These are done in case now there are other additional upper airway problems, such as if the soft palate is enlarged, and if you have a patient with floppy epiglottis and such. Maxillomandibular advancements also have been shown to improve symptoms. Hypoglossal nerve stimulation, it's one of these new techniques that have been employed, and it has been shown to improve symptoms in OSA because we had mentioned that what we are trying to do is to open up the upper airway, and one of the muscles that we are targeting are the tongue muscles, the genioglossus muscle. So what this nerve does, it directly stimulates the muscle. So once this muscle is stimulated, the tongue falls forward and it allows air to go through, okay? So in conclusion, OSA is a common condition and the prevalence is rising. So how do you diagnose? So the 3 S's are snoring, sleepiness, and significant other observes the apnea, especially in adults. OSA affects multiple organ systems, as we mentioned. And of course, in children, it's important because there are lifestyle and behavioral changes that come as a result of long-standing obstructive sleep apnea. Treatment options such as adenotonsillectomy has been shown to improve symptoms, and it has been shown to improve the consequences that can arise due to untreated obstructive sleep apnea. So these are my references. Thank you very much for listening.
Shukran jazakallah khair, Dr. Abu Fatah. I think it's taken as obstructive sleep apnea, which is a common problem. And one of the commonest causes, of course, is obesity. Okay? And of course, in pediatrics, most of the terms are mechanical causes. So we will take one burning on fire question.
Assalamu alaikum. Thank you for the amazing presentation. I believe obstructive sleep apnea also has as dentists, we have a role to play in obstructive sleep apnea. We have seen that the tongue is the main culprit. So for a growing patient, it is important as parents to look at how your child is sleeping. If you notice that they are sleeping with their mouth open, maybe because of the adenoids being swollen, then it's important to ensure that they either see a dentist or you address it. Some parents even go ahead and, okay, with an advice from either a doctor or a dentist, tape the child's mouth when they're sleeping, so that the muscles in the body usually have memories. When they adapted to breathing through the mouth, then it becomes a habit. And that is developed usually when they have a cough or flu that causes them to breathe through the mouth. So it's not something that should happen continuously. So when you notice that your child is breathing through the mouth, especially during breathing, you don't want the muscles to create a memory. So you either tape their mouth or you ensure that you lift their mouth up. Another question that I would like to ask to the audience is, as you're seated right now, where is your tongue positioned? Okay, so the tongue is usually supposed to be positioned on the top part of the palate. If your tongue is not there, then it's supposed to be trained to stay there. Because if it's low, then we obstruct the space and we create such issues. So I believe the mouth is also having some huge contribution in obstructive sleep apnea. And there are some trainings that you can do, like for 10 minutes every day, you stick your tongue on top of the mouth to train it to stay in that place. 10 minutes every day for about 3 minutes to train the tongue to stick to the roof of the mouth. Thank you very much.
Thank you. So sleep is very important. Okay, we need to sleep, but don't sleep in class. Okay, studies have shown that extremes of hours, that less than 5 hours of sleep, and also those who sleep a lot, more than 8 hours to 12, have been shown to cause arterial stiffness and increased cardiovascular risk factors in patients with diabetes. So we should sleep. We should have good sleep hygiene, but not sleep more than 12 hours. Burning?
Yes. This opportunity, I want to ask a question on OSA related. We know that OSA can interfere with do we give, you say the best management is CPAP. So do we do CPAP plus the insulin or CPAP with the oglars? How do we manage diabetes and OSA?
Okay, thank you for that question. So if a patient already is diabetic, and presents with symptoms OSA, of course you'll need to continue with your diabetic treatment and prescribe CPAP, okay? But if I get your question right, probably, are you trying to say a patient who you are suspecting to be diabetic and has OSA? Is that what you're trying to say? Okay. For patients who on the borderline, I'll say on the borderline of diabetes, and you are suspecting probably you want to start treatment and has OSA, you'll have to first consult your diabetologist to see if there is a need to start treatment as you manage your OSA. But also remember that studies have shown that those patients who have been started on CPAP therapy have been shown to improve symptoms in terms of, unfortunately, it's hard to assess the response to your CPAP therapy because at the moment you can do PSG, but it's expensive. It's around 50,000 to do a sleep study, one sleep study in Nairobi, Aga Khan University Hospital. So it's going to be a bit, I'm not sure if it's going to be cost effective if you are to refer a patient just for a sleep study to assess your response to therapy. But what I'll say is that generally it has been shown if these patients are compliant to CPAP therapy, they tend to improve symptomatically, especially the AHI index, so the apnea-hypopnea index improves more than 90%. That is a very good response to therapy, okay? And if you're suspecting that, now how do you balance the two between the diabetes and the OSA? Then of course, in consultation with the endocrinologist, you need to make a decision there. Thank you.
A question before I'll comment on that.
And thank you, Doc. I had a question. And lately, I don't know if some of us have seen, but there are small gadgets, magnetic ones, that people put on their noses to open the nostrils. I don't know if they have a role in management of OSA and if they improve breathing. Do they work?
Yeah, they are known as mandibular enhancements. So it's actually one of the treatment options, medical treatment options, because these are like gadgets where patients actually bite on them, because what they do is that they tend to widen the space between the mandible and the maxilla. So when you're sleeping at night, it enhances airflow better compared to when you're not wearing them, okay? I didn't put up an image here, but it's one of the medical options that you have. So we also have another one known as where it's a plastic, sometimes they come in plastic, sometimes in silicone, where you insert it in the tongue, then they pull the tongue forwards. So when the tongue is pulled forwards, you increase your oropharyngeal airway space, okay? And that is the same concept with what you're trying to say.
Just talk from hypertension. So hypertension and arrhythmias, once it's with obstructive sleep apnea, we know from cardiology you will use less tablets, lower doses, if your obstructive sleep apnea is controlled. For episodes of AFib, the frequency will reduce and the burden will reduce if you treat both AFib and obstructive sleep apnea. In fact, for those who go for ablations, for atrial fibrillation, to treat atrial fibrillation, if you're not on CPAP, you're not recommended to go for an ablation because there's much higher recurrence, failure of the procedure if you're not taking care of obstructive sleep apnea. So it's very good. Number two, a senior brother just sent me a message. We have a very big group of junior colleagues here, nurses and doctors. From these talks, pediatric cardiology, in-vitro fertilization, and OSAS, if you're not, there's always been something that the presenter said we don't have. It's a test, staff, human resource, skill. That's an opportunity for the younger colleagues to try and consider to do that to fill in a gap. Not all of us can do clinics, locums in an internal medicine, surgical, pediatric, and psychiatric, but those are opportunities, and one of the benefits of coming for these conferences to pick up what is not there for me to do and give myself an opportunity in the market. Okay, and I hope you'll keep on, because the next session is about having opportunities in medicine, and that's one of the ways, inshallah. Thank you.
So if I can comment on the same line, the test is in Nairobi, apart from Aga Khan. MP Shah has it, and Nairobi ENT also has a sleep center. In addition, most of the pulmonologists in Nairobi also have the home-based devices, and it's costly around 20 to 30,000. So if you have a patient, you can just refer to any of the pulmonologists. And there are many other centers coming up. So I know at least those three. MP Shah has a sleep center, and the Nairobi ENT also has a sleep center.
Shukran, Jazakallah khair. Can we give another round of applause to Dr. Fatah? So there are a lot of opportunities. Actually, you can be a sleep specialist, and it's an opportunity. Dr. Zahra had told us you can be an embryologist, and of course, Dr. Abdul Karim emphasized on research. Okay, so we can look at all angles, and of course, the presentation by Dr. Zainab in pediatric cardiology. So we are meeting here in okay. So we are going for a 15 minutes break. So we should be back here by 11:25. We encourage you to go take your tea at the Expo Center and also visit some booths. There's an excellent and exciting panel discussion on career, and we have some of our professors, Professor Zahida Qureshi and others who will be part of it. And I encourage you all to come and listen. I also encourage you all to visit the booths, and for those who did the signing of the booths, you can return the paper to Kammp. Of course, as I told you before, there are exciting gifts to be won. So make sure you filled it. See you in 15 minutes.